We are live.
Okay, so good morning and welcome everyone. In our Fellows Academic round. And today we have a very interesting topic, acute Monteggia fractures. And we have a we have Dr. Tushar Agrawal with us to present this topic. Sir is a renowned pediatric orthopedic surgeon from Mumbai. Sir has done various pediatric orthopedic fellowships in India and abroad and has a lot of papers and publications to his credit. After the talk, we have two interesting cases, and I would like all the delegates to ask whatever questions they have. They can type them in the chat box, and we'll try to get the answers of all these questions. And if at all some questions are left, we'll ask the faculty separately and text and write them on the fellows group. So, without wasting much time, I'll invite Dr. Tushar to please share his screen and start the talk.
Yeah, good morning, guys. Bear with me as I share the screen. Is this now visible?
Yes, sir.
Yeah, great. So good morning to all of you all, and thank you very much for joining us on this Saturday morning. I would request Gaurav to, sort of please keep giving a sign that I am still continuing to remaining visible and audible, because, otherwise you realize as if you're talking just to the screen.
Right.
Right. Great. Thanks. So what's really happening today is the iFix is happening, and many people who are interested in pediatric trauma talks would be busy there. So hopefully those who don't join us live may want to see it on OrthoTV at a later date. So it's always better, I've learned, to start with a story. So this is a true story that has happened with me. So I got a 6-year-old boy referred to me by a pediatric surgeon. Okay. And the pediatric surgeon had been referring to me regularly pediatric orthopedic patients. And this child happened to be a doctor's grandchild, a doctor whom I knew pretty closely. Once they came, I happened to realize that the parents are deaf and mute, but highly functional and literate. And the child seemed to be having a very simple, sort of a unassuming kind of a fracture ulna. And for some reason, nothing clicked to me. However, I had told them that, boss, you got to follow up very regularly. And so pronto they came after about 3 to 4 months. I had treated them in a slab and I had almost forgotten about it. And when they turned up, I saw that the child has some hyperextension at the elbow, and it made me wonder, and I got worried, and I got this X-ray. So what has actually happened was that, as you can see here from the ulna, probably the child had a plastic bowing or some sort of a subtle Monteggia to start with, which probably even I, in spite of being a pediatric orthopedic surgeon, had missed. So you can just imagine what can happen to people whose eyes are untrained to pick up the Monteggia fracture, and it happens very regularly. So the story goes on. The parents were highly displeased, and the grandparent was highly displeased. I was also feeling aghast with myself. At what point did I miss? I am aware I gave talks on Monteggia, and what went wrong? So they went all over the city. Mercifully, they didn't get any terribly negative feedbacks. They came back to me, and this is what I had done for them: a posterior distraction angulation osteotomy of the proximal ulna. And I confirmed that the radial head was reduced, and the patient's doing well now. The implant has also been removed. So if you look up indianqanun.com, there is in 2015 and 16 and many more cases have gone against doctors for actually missing Monteggia fracture. So what I'm trying to say is that even in India, the medical legal system is alert, and it really calls for us to really pick up our Monteggia fractures acutely and treat them acutely, as you shall see that the outcomes in a missed Monteggia are never as great as the outcome would have been in a primary Monteggia treatment. And imagine the genius of the man who first described the Monteggia lesion. He described it in 1814. Okay, 1814. That was way before the first X-ray was ever done in humanity. That is in 1895. And now, in spite of the latest imagings, we continue to keep missing Monteggia fracture. And I wonder at the genius of this man, to describe a lesion 70 years before X-rays. So now let's take up another story. So I got this X-ray from a medical college where I visit very regularly as a visiting faculty. And the AP X-ray was unassuming. The lateral X-ray, as you can all see, is showing our friend, which we are talking about, the Monteggia fracture. So I told him, boss, I was interested in the case and I would like to come over and do the needful. So he kept the case for me. Unfortunately, I could not go the next day, and yet the next day, and I actually got delayed by 7 days. So this plastic bowing remained like that for 7 days. In spite of the fact, I felt, no, I may be able to achieve close reduction. And as you can see, in spite of my attempts, within 7 days, the Monteggia had become irreducible. So that means an acute Monteggia fracture with a plastic bowing with an anterior dislocation of the radial head is like an emergency. If you delay it by a couple of days also, it gets converted into a missed Monteggia. And see what happened. I had to expose the ulna. I did it at the proximal third. I osteotomized the ulna and I thought, okay, now since it's only 7 days, I'll get the radial head to budge, but it would not budge at all. So I'm a fixator guy. I thought, chalo, this time I'll apply a JES, and I gradually distracted, thinking that just by distracting, I may be able to reduce the radial head, and it still would not come. So I had to actually take an incision and get it in, and expose the radial head just to confirm that the radial head is in. So it became so much of a procedure, and then we replaced the fixator with a plate. Okay, so we had to actually do a fixator assisted distraction angulation osteotomy in just a 7-day-old injury. Okay, and you can see some amount of radial angulation, which sometimes becomes quite inevitable. So I'll later on explain what you have to see when you do these surgeries to make sure that your radial angulation has not gone terribly wrong. Okay, so here you do feel that the radius is still a little anterior, but we will learn more about the radiocapitellar line as we proceed. Right. So this fracture eventually went on to a good outcome. Okay. As you can see, the X-rays from the comparative side, we've got it all sorted now, reducing it. So I'll introduce the first sort of radiological parameter. Some of you may be already knowing it, some of you may not know. It's called the MUB, that's the maximum ulnar bow. So many of our Monteggias which we are going to receive are having an anterior bowing of the ulna, right? And this is the technique. You would draw perpendicular to either ends of the ulna and then draw a perpendicular line in between. So that's the flat horizontal touching the proximal and the distal ulna, and then you calculate the maximum ulnar bow. Ideally, there should be no ulnar bow, and depending upon how much is the magnitude of the ulnar bow and the position at which the ulnar bow is, that would determine whether you will require an ulnar osteotomy, an open reduction, and the other things. So learn to remember this one concept called the maximum ulnar bow in the plastic bowing of the ulna. So that's your first radiological learning point for the day. And it has been proven in a few articles that the closer the maximum ulnar bow is to the radius, that is more proximal, the higher the chances of you requiring an osteotomy. And more distal the maximum ulnar bow, the lesser the chances of you requiring a osteotomy and it being managed by a close reduction. So now one would ask, why is Dr. Tushar talking about all these plastic bowings and these semi-missed Monteggias when he is actually supposed to be talking on a acute Monteggia fracture? So the reason is that the Monteggias may rarely present like this. This is like staring in your face, more like the ones which Monteggia described before the presence of X-rays. You can make out that there is something ghastly going on here. But actually speaking, most of our patients would come with plastic bowing and a subtle subluxation of the radial head, which in spite of our best knowledge, we may miss. So now, what is the classification that you would use? So most commonly, you are used to understanding the Bardo's classification. But I would say that let's Bardo. What I mean to say is, remember now that all Monteggia are classified like let's Bardo. You can also say it as let's Bardo to remember it as a mnemonic, but let's Bardo means you add the let's classification on top of the Bardo classification, because a bulk of our patients are going to be in the green stick type of plastic deformation, which is not really classically described in the classic Bardo classification. The Bardo classification starts straight away with the let's type C, that is the anterior angulation with a fracture with a radial head dislocation. All of us will know, we are already very qualified, that the Bardo type 2 will be the posterior angulation, posterior radial head dislocation. The type 3 is the radial head dislocation, radial angulation, and type 4 is the fracture of both the bones with radial head dislocation. But few of us would be totally familiar with the LETs. So let's familiarize ourselves with the LETs. The LETs type A is the anterior angulation. The LETs type B is the anterior green stick. I feel these are more commonly seen and missed, so this is very important. The LETs type C matches the Bardo type 1, and the LETs type D is the Bardo type 2, and the LETs type E is the Bardo type 3. So LETs leaves the Bardo type 4 to Bardo only. It does not include the classification. So together we have everything. So henceforth in future, for all those who attend this talk, the classification is Gaurav, let's Bardo. Okay. You merge both of them. Am I still audible, guys?
Yes, sir. Yes, sir.
Yeah, great. So now, in our era, whenever we used to be talking about pediatric trauma, we had K. Wilkins, and every year K. Wilkins used to come and take part in various pediatric trauma workshops. And most of the current faculty of IFIX have been students of K. Wilkins. So I thought that let's take a page out of K. Wilkins' talk. So there's some very interesting things in his article. So first thing he says is that trash every other injury mechanism. What is happening in the Bardo type 1 is that there is a hyperextension of the elbow, and that is causing the anterior dislocation of the radial head. So he says very cleverly that for all anterior dislocations of radial head with anterior angulation, all you need to do is flex or hyperflex. Okay, so Bardo type 1 for close reduction of all management or practical purpose requires flexion. So there is reduction in flexion, right? And you have to get a posterior angulation of the ulna. For the Bardo type 2, it's exactly opposite. So it's a flexion type injury, which you actually reduce in extension or hyperextension. And he goes to the extent of saying that for Bardo type 2 and for Bardo type 3, if you're going to treat in close reduction, you may actually give a cast in extension. Many of us would be familiar that we can actually give an above elbow cast in extension. So then you can get this close reduction. 2 points for above elbow cast in extension is you have to do an above elbow contouring here at the supracondylar level, and you have to give a thumb out trigger like a thumb spica extension so that the cast does not slip out. Gaurav, you got that point, right? I'm sure you know about it, but just to concur with me.
Right, sir.
Yeah, great. Thanks. And in type 3 also, he says you could attempt a close reduction. Okay. Only thing is in type 3, what happens is type 2 and type 3 both, there is a chance that you may injure the posterior interosseous nerve. And as we shall see as one of the case I'll be presenting, it's an actual reality that you can injure the posterior interosseous nerve. Though it's not as common, but it is a realistic possibility. Okay, and Bardo type 4 definitely is not amenable to close reductions, and it has to be operated upon. So this is from the K. Wilkins talk. So what have we gleaned till now? That we must have a fast pickup of the Monteggia. So that means you should highly suspect it. You should focus on close reduction because the literature supposes that bulk of the Monteggias can be close reduced. If you are close reducing, you have to monitor the radial head at a weekly level. Okay, and you will get a great outcome. Okay, most of the type 1 What I mean is most of the type 1 and all of type 4 will need surgery. A rest are rare, but can be managed conservatively. So type 2 and type 3, okay, can be managed conservatively. Up till now, this is what we are getting from the K. Wilkins article, but we will see what happens. When I say most of type 1, which means is that length unstable ulnar fractures and all type 4s will require surgery. So let's proceed and let's do some more stories. So we have one more plastic deformation of ulna with radial head dislocation, and you can see very well what's happened. The MUB is in the center of the ulna. And then we went ahead, we just directly, we could not close reduced, and we had to, as you can see, again, there is a slight radial angulation, but the radial head is in, and you can use a 2.7 or a 3.5 plate as per the age and profile of the child. And we got it all reduced here. This was done acutely. And you must be wondering that why is Dr. Tushar talking about operative now again when he said that this can be close reduce. So we do close reduce, the ones which are amenable to close reduction, and you have to give cast in flexion, and you have to really monitor the radial head. So we have do we have an algorithm in place? So we do have, right? So we have that all plastic ulnar deformation and green stick fractures, you will do close reductions. For the length stable ulnar fracture, some people may still go for close reduction, but most will use intramedullary fixation and casting. And obviously for the length unstable ulnar fractures, you are going to do open reduction and plate fixation. The more aggressive algorithm takes away the close reduction from the length stable and recommends intramedullary pin fixation for all type 1 Monteggia fractures, which are fractured completely but are length stable. Okay, so now there are these two articles, one got by Foran and one by Ramsky. The Ramsky article came out in 2015 and the Foran article came out in 2017. So as you can see, they have the lead big authors, Peter Waters, Flynn, all you guys from the Dr. Moulin's table will know all these guys personally, Dr. Upasni. So what is happening is that, you know, they divided their population, Monteggia population, into 3 categories. They did like a prospective study. So what they found is that, is there any issues? I can continue, right?
Yes, sir.
Yeah, great. So what really happened is that you divided your patient population of Monteggia into 3 categories and you became ultra conservative in some. You went exactly as per the algorithm which I mentioned just now in some, and you got very aggressive. That means you virtually operated everybody in some. And as you can see, there are 0 failures when it comes to when you get aggressive, you know, when you play as per the strategy or when you are aggressive. And you get lot of failures when you are ultra conservative with Monteggia fractures. So this was concurred to some extent by the Upasni study. However, they said is that you don't need to get ultra aggressive. So as you can see, they don't have any ultra aggressive. So they didn't operate on all the patients, but they went exactly as per the protocol mentioned. So we'll just quickly see the protocol again. Is that the length stable plastic deformation and green stick are close reductions. The length stable transverse and short oblique is intramedullary fixation. And the length unstable are the long oblique comminuted or open reduction. But you have to understand that to be able to conserve an acute Monteggia, you need to be able to reduce the ulnar fracture and you need to be able to reduce the radial head. And you have to be able to maintain these two in a cast. Okay, so that is the top criteria for conserving. Now, yet another story, and this was not mine. And this again, within a week's time or within 2 weeks' time, I got this injury. And this again was an anterior green stick. This is what I'm trying to tell you. This is what everybody misses. And again, this patient required the same kind of proximal ulnar osteotomy, healed and has gone on to implant removal. Now, quickly, we are very familiar with the radiocapitellar line, but this wonderful article actually assessed whether the radiocapitellar line is as accurate as it seems to be. So this is a normal elbow, right? And they have told us that, see, in the normal elbow also, depending upon the position in which we do the X-ray, the long axis of the radius may not bisect bisect the capital. It can transact the capital. So mere transaction is enough, right? So don't worry to bisect the capital. So this point is very important in assessing your close reduction after reducing your Monteggia. So you don't have to keep worrying that the radial long axis from the radial shaft has to actually bisect the capital. It has to merely transect the capital. And they went to the extent of saying is that if you take the long axis from the radial neck, there is a higher chance, as you can see this, of transecting the capital, rather bisecting the capital, right? So this is a very important point. Second radiological point. The first I taught you was the MUB. The second is the newer thoughts on the radiocapitellar line. And now you have something called as the lateral humeral line, right? So you draw the long axis of the humerus and draw a parallel line from the lateral most ossified part of the metaphysis of the distal humerus, right? Are you all guys there with me?
Sir.
Yes, sir. Yes,
Yeah,
sir.
great, superb, right? Great. Thanks for the reinforcement. And then
Yes,
you will
Tushar.
start. Molin, you are also
Tushar,
listening, right?
I'm leaving, but I enjoyed your talk so far. It's going well.
Yeah,
Take care. I
thanks.
have a lecture in IFIX, so
Yeah, great, great. Best of luck.
take care. Yeah.
Right.
Bye.
So lateral humeral line, okay, and you will find that the lateral humeral line should be lateral or tangential to the radial head or to the radius. So what they are trying to say is that when you see a lateral humeral line intersecting the radial head on the AP view, that means there is a lateral subluxation of the radial head. So that is precisely what I meant when I showed you my earlier X-rays. If you remember, I had a slight radial tilt. So am I subluxating the radial head laterally? So I'm going to look at the lateral humeral line and I'm going to understand that no, I have not subluxed my radial head laterally. Okay. So now when we are at Monteggia fractures, we should also focus on Monteggia equivalents. The original Bardo classification had its own fair share of Monteggia equivalents, and the Monteggia equivalents actually focus on complete elbow dislocations along with ulnar fractures. They focus on segmental ulnar fractures along with radial head dislocations, and they focus on radial neck fractures. Okay. Now people kept adding Monteggia variant. They kept adding, and the beautiful article which has remained hidden, it's a hidden gem, I must say, is by a professor called Dr. Bhandari. Okay, Pankaj Jindal is very well known. He's an hand surgeon, but Dr. Bhandari is actually from Ahmedabad. And I'm sure Maulin may be knowing him. Maulin has now gone. And he had this wonderful gem of an article whereby he subclassified the type 4. So fracture of both the radius ulnars in various directions with various dislocations of the radial head. You could maybe look up this Dr. Bhandari's article and further read it, right? It's a great article. So numerous people have gone on to describe numerous Monteggia equivalents, type 1 equivalents, type 2 equivalents, type 3 equivalents, and type 4 equivalents. Our interest arose because we published our own article with my fellow Dr. Pavan Soni. It was a great experience getting this publication in, whereby we had a intermediate variety between type 3 and type 4. So what was happening in this patient was that we'll show you this case in great detail at a later date. We'll just discuss that. So now the numerous people who have come with numerous classifications for variations of Monteggia equivalents. But what you need to know, or what I have concurred from these classifications, is that you will have some deformity or a fracture of the ulna and a radial injury proximal to this level. So any radial injury proximal to the radial fracture is almost now sort of considered to be like a Monteggia equivalent. So even if you have a shaft radius fractures coming close to the radial neck, along with a radius fracture, along with an ulnar fracture distally, you can almost consider it to be a Monteggia equivalent. But predominantly all radial neck fractures with or without radial head dislocations are the lead varieties of Monteggia equivalent. So be alert and classify them as Monteggia equivalent. So let's quickly go through our case which we published. So this is how we received and it looked like an innocent green stick radius ulnar fracture, but for the fact that we had a radial dislocation of the radial head. But we also had both the bones fractured. So was it a type 3 or is it a type 4, right? So actually speaking, it's an intermediate variety between type 3 and type 4. And under anesthesia, we had terminal supination was restricted. We were confirming whether we had been able to reduce it completely. Okay, so we manipulated, corrected the radial angulation. We got the radial head in, but we found that it would quickly move out. And lot of pressure was required by our hands to keep this radial head in. Okay, so then what did we do? We fixed the radius first. Why did we fix the radius first? Actually speaking, everybody would feel that we need to stabilize the ulna since this is a Monteggia variant. But we actually wanted to convert the type 3 Monteggia, type 4 Monteggia into a type 3 Monteggia. So we fixed the radial head and then we did a distal to proximal ulnar nailing as well. Okay, and this patient had implant removal and is doing well now. Now let's go and see one length unstable. This is a highly uncommon injury, reaching your casualty like that with a puncture compound wound. And actually you would feel it's a compound forearm fracture. But if you look closely, what has happened? The proximal radius has moved out. So this is a Monteggia variant, as we have just said, right? So this is length unstable. So we had to reduce the ulna and then also stabilize the radial neck with a tense nail. This patient is yet due for implant removal and doing well. Now, one case I'll present that's of Taral. So this patient, somebody else attempted forceful Monteggia close reduction and actually caused a posterior interosseous nerve palsy. So that's also, whenever you see a proximal ulnar fracture like this, okay, be alert to the fact that while attempting close reduction, you can cause a posterior interosseous nerve palsy. Okay, and if your close reduction is very tough, then don't hesitate to go ahead with the open reduction. This is where the posterior interosseous nerve was entrapped between the radial head and capitulum. Okay, and they released it, and pronto the reduction was good. They repaired the capsule, and you can see that the patient recovered the interosseous nerve almost immediately, started and had a good follow-up. So I have taught you 3 new points on X-ray: the maximum ulnar bow, the radiocapitular line current concepts, and the lateral humeral line current concepts for the AP view. I have also taught you the alphabet of Monteggia. So anticipate that every elbow and forearm fractures can be Monteggia. I don't want to miss it. So be prepared, cross-verify by doing opposite elbow X-ray. Make a firm decision. I'm going to do a close reduction. If it fails, I'm going to do an open reduction. And I have to be prepared for both. Evolve your own treatment modalities as you grow and focus on getting a great final elbow function. Now, with a final caveat that in my practice, I'm very aggressive on Monteggia and I'm sort of unable to really go with the conservative line of treatment, but the literature favors both, right? So the judgment is out there in the literature. It's pretty equivocal. You can take a call whether you want to conservatively treat your Monteggia and monitor it or you want to operate it. So that's my last slide. We can now go on to the case presentations and we can take some questions and discussions.
Yes, Shyam, I would like you to please discuss the question which I shared in the chat box. Shyam, are you there?
Yes, sir.
Has Atul Bhaskar joined us?
No, sir. Sir has got an emergency case. His case
Okay.
will be shared by me.
First question is from Anil Agrawal, sir. In case of requirement of open reduction of radial head, how do you ensure that radial head is accurately reduced?
So you have to take your AP and lateral views, and that's it. And you have to, if you're doing open reduction, then you can actually see the radial head sitting, the cartilaginous radial head sitting against the capitulum. The problem is not actually reduction. The problem is you don't want to over reduce or move it in some other direction. And the problem is that once you take past the transcapitular wire, you can't really take an AP view. So that is the problem, that you can't really take an AP view. So you do your close reduction, first do the AP and lateral conformation, then pass the transcapitular wire. I personally don't retain the transcapitular wire, but there are some literature evidences where they are keeping one thick transcapitular wire to maintain the reduction. I hope that answers the question.
Yes, sir. Next question is from Anil Agrawal, sir. What to do about lateral deviation if radial head is reduced?
See, I have been also unable to actually control the proximal lateral deviation. And the K. Wilkins mentioned about abnormal muscle forces when you are doing the proximal ulnar osteotomy. So as long as you are well within the lateral humeral line, you are not really laterally subluxating the radial head. So you don't have to worry, is what my conclusions are. And I have done many cases now with that proximal ulnar radial bow, and nothing has gone wrong with the radial subluxation. So you can go ahead with your proximal ulnar osteotomy, try to control as much as possible, but the muscle forces may cause some amount of radial deviation.
Uh, Sir, one question is if there is associated coronoid fracture, then how should we approach that?
I have never had an opportunity to treat such a patient, but I would feel that a coronoid fracture is generally always with an elbow dislocation. So that means this is a Monteggia variant. So you have an ulnar fracture also, I presume, if we are discussing Monteggia, or you have a pure coronoid fracture and there would be an elbow dislocation. So you assess the stability of the elbow, and I think you can conservatively treat that patient. I have never had an opportunity to treat operatively a coronoid fracture of the in a pediatric elbow.
Sir, next question is from Anil Agrawal, sir. Your choice of implant for Monteggia, is it IM nail or plate?
So the literature says that for the length stable ones, you can use IM nails, but I have always been using plates out of habit because, more as a pediatric orthopedic surgeon, I was probably receiving more of missed Monteggias. So I sort of got acclimatized to using the plate, but I think for acute Monteggia, you must use IM nails for length stable, and for length unstable, you use plates. And you should try to use the 2.7 plate. It's a lower profile implant. And the distraction, the slight amount of gap which you create gets filled up. I don't think you require any form of bone graft for that. I am sure Maulik will cover as to when you want to put bone grafts, how much of distraction actually requires bone graft in his talk next week on missed Monteggia.
Yes, sir.
Okay. Yeah, so if we don't have any further questions, Shyam, you can start your case.
Okay, sir. Is it visible?
Yeah.
Okay. Good morning, everyone. I'm going to present a case of 13 years old boy who sustained a closed injury along his left elbow. He had history of fall from a tree of approximately 8 feet height on an outstretched hand. On clinical examination, he had tenderness and swelling along his left elbow, and there was paresthesia in ulnar nerve distribution. There was clawing of little two fingers. There was no other neurovascular deficit. AP and lateral view of his affected site has been shown here. Can anyone read this X-ray?
Anybody from delegates you want to read this X-ray?
I think if you are paying attention to my lecture, it should be able to, or either you are feeling very sluggish. So I would feel that this is more like the one of the variants which I showed. Monteggia variants with elbow dislocation. So ulnar fracture means it's Monteggia, and radial head ulnar fracture with dislocation. And now this is a Monteggia variant because there's a complete elbow dislocation, and probably I think some radial neck fracture as well. The radial head is also dislocated.
Yes. Yes, sir. So,
One point. Can you go back to the X-ray, Sheena?
yes.
So apart from that fracture in the radius, you can see that the radius has shifted all the way towards the medial side.
So it's like a translocation.
Yeah. Yeah, Sheena, you can go ahead.
Yes. So, what would you name this fracture? We can, if we see comparative radiograph with the normal side, we can easily appreciate the radial shaft translocation to the medial side, which can easily be overlooked in the only if we see the affected extremity X-ray. This was the comparative radiograph lateral view. So now we can make the diagnosis that it is convergent elbow dislocation with radial neck fracture and concomitant ulnar fracture. So how should we approach this, sir?
Well, you will obviously require to open reduce the whole thing. I have never really had an opportunity to deal with a translocation, but I think this is more like a neck fracture, right? And you have to now get the radial head in. You have to take the proximal radius, move it radial wards, rigidly fix the ulna, or maybe whatever, nail the ulna, and then probably the radial neck also could be nailed or for stability. So I'm not familiar with your case, so you can go ahead and let us know what you have done.
Okay, sir. If we see literature till date, this was the first case which was described by Maxwell. That was a convergent dislocation of the elbow with the initial injury, with the original injury, not after dislocation. Till date,
I'll just interrupt for the benefit of the delegates that the classical Monteggia which I described, no, that generally remains restricted to the first decade. So as you note, this patient is 13-year-old. So all these variants, the Monteggia variants, the translocations, you start suspecting more when they become more than 8-9-year-old and they get injuries, right? So I think age matters a lot. Go ahead.
yes, sir. Till date, there are around 25 cases of convergent elbow dislocation, which have been reported in the literature. 2 cases were reported by Royal Hospital for Sick Children in 1991. These were the X-rays of the patient reported in this study. Our case was different from these cases, as our case was also having ulnar fracture as, along with the convergent elbow dislocation. This was the case reported by Dr. Sheetal Parikh in 2014. They concluded that close reduction is usually unsuccessful in these type of cases, and elbow remains unstable until radial head is open reduced and fixed. And if diagnosed quickly and treated early, it ends up in good outcome. Open reduction, if we see the literature, we see the open reduction and internal fixation is required in almost 78% of convergent dislocations, which might be due to the pseudo-osseous block between radius and ulna. And if we see the divergent dislocations, it is easily reduced by close reduction, and open reduction is necessary in only 10% cases. only if there is associated radial head fracture.
So for the for benefit of our all the group, I would presume that when you're saying divergent, it has not crossed over. And when you're saying convergent, it has crossed over, right? So the radius is on the ulnar side and the ulna is on the radius side. So that's why it's a more aggressive injury. And divergent is like this, right? So it's on the same side. So you're pulling it back, right? Am I right?
Right.
Yeah.
Yes, yeah. So we also face the same thing. Let's see. Our case had also concomitant ulnar fracture, which has not been reported in literature. And we firstly reduced it close. We did close reduction under anesthesia, but after that elbow was found unstable. Then we did ulnar close nailing, and after that also elbow was still dislocating. Then we did open reduction of the radial neck fracture and fix it with the K wire. Then finally we get stable reduction. As we also face the same thing as described in the literature, that elbow was unstable after close reduction if we don't fix radial neck fracture openly. These are the intraoperative images. Radial head was approached via lateral approach by making plane between the enconeus and extensor carpi ulnaris. Radial shaft was brought laterally and radial head was located over it. These are the intraoperative IITV images. We can see firstly we fixed the ulna and then a radial head was fixed with K wire. These are the follow-up X-rays at 2.5 months. K wire was removed after 3 weeks. We can see healing and callus. These are the X-rays at 1.5 years. We can see fracture is well healed and well located ulna and radial head in its position. These are the follow-up images at 1.5 years. We can see full range of flexion and extension is there, and almost full supination is there. So the take-home message is it is the first reported case of convergent elbow dislocation with concomitant ulnar fracture. Despite of associated injuries, the result was excellent. The main crux is early diagnosis and treatment in the form of open reduction and fixation is the key to successful long-term result.
So you got a great outcome, but AVN of the radial head, with it becoming larger in size, is a problem. I think one of the benefits is the older the patient, probably we get a little better outcome. So if the same injury would have been there in a younger kid, I sometimes feel that the radial head AVN could be worse and could have led to stiffness and we would have not been able to do much. So I would feel if this patient would come into my practice, I would do the same management, but there would be a lot of counseling that you may lose about 10 to 15% of your movement range at the end of your treatment. That may not be possible. You got a great outcome, but it may not be possible to give full extension and so just little 10 to 15% loss of movement may be there. So yeah, great outcome. We'll go to the next case. Or if there are any questions, then we can take.
Yes, sir, I'll share the case which Dr. Atul has shared. Shyam, can you stop?
Yes. Thank you, Gaurav sir and Molin sir, for allowing me to present this case.
Nashinam, you did a good job. Yeah. Thanks a lot.
Thank you.
My screen visible to all?
Yeah.
Atul sir, are you there? I think it is Ashok.
Is this live, Atul, or is this?
Yeah, I think it is recorded.
It's a recorded talk because this is a hotel room he was living in the COVID times.
So I don't think how I can dissociate it with the audio and present it.
But I'm sure if you run it as a PowerPoint, it will come with the audio. I think उसमें कुछ एक settings में जाके from the OrthoTV guy, do we have the gentleman who was there?
If I can do it without making it full screen, is visible to everyone.
हाँ, but आप share audio करोगे तो the presentation will come with his audio.
नहीं, मैं share audio करूँगा नहीं. Can we present it in this just without making it a full screen? No? Yeah. So this is the case. 24 months chronic case of Monteggia. I think it has been operated earlier also.
So here I'll bring the point of the lateral humeral line.
Right.
Yeah. So,
right. So if
so
we can
the
discuss
lateral
this
humeral line should be seen. Yeah.
So here we can see that it's a type 3 Beddoes, lateral dislocation of the radius, angulation of the radius and ulna over the lateral side, and this has been operated earlier. So now this was done by Dr. Atul, and this lateral deviation of the ulna was corrected, and as we can see that now the radius head has started moving in at its appropriate place, and the elbow flexion has improved. The curvature of ulna has decreased. This is the same child. Yeah, this is the same child, and now we can see that he has got good function, good pronosupination, some restriction of pronation, but full supination and almost full elbow flexion and extension. Right, sir? And the head looks very fresh.
So again, that slight radial tilt of the proximal ulna. So this is always going to remain as long as the lateral humeral line, the radial head remains well within the lateral humeral line. I think that was a good parameter when you're treating acute Monteggias. Right. So as we can see, such a ghastly case Dr. Bansal showed, and she, along with her boss Maureen, could give such a great outcome because it was treated well acutely. And what really happened here is a lot less ghastly case, which could have been managed acutely, was not managed, and we've lost some degree of pronation. Twice has been operated on the proximal ulna, and there's so much a problem. So never let a Monteggia go amiss, you know. I think is the take-home message. Be highly suspicious. Think of every forearm, elbow injury as if it's a Monteggia only. Keep looking at the radial head very accurately. Keep worrying, you know, especially if your radius fracture, if your shaft radius fracture is proximal to the ulna fracture. I have started feeling you should start thinking, can this be a Monteggia variant? Keep looking. Keep seeking out the new Monteggia variants. There are millions of new Monteggia variants.
Right, sir. So we are well in time, and thanks a lot, sir, for such a nice presentation, and it gave us more clarity on all aspects of managing Monteggia and diagnosing Monteggia.
I feel it's really very difficult to cover everything what is given in a textbook, and I'm sure you guys can read the articles in the textbooks and glean more. But the primary message I wanted to give is that most of them would come in the form of this anterior green stick, plastic bowing, and and it doesn't strike you, and it becomes a missed Monteggia.
Right.
So look out for these subtle variants, and pick it up as an acute Monteggia, treat it acutely. Right, guys?
And the way you presented in a story format kept all of us engaged and inquisitive for the talk. Thank you, sir.
Great. Yeah,
Thank
great.
you, sir,
Thanks for the opportunity.
Thank you, sir.
Thanks,
Thank you, everyone, for being a part. And if anybody has any questions, they can share with us on the fellows group, and we'll ask Dr. Tushar. We'll get the answers and share them back. Thank you, everyone, and we'll share.
Have a great day.
Right. Okay. Thank you.